Prescription drugs are regulated in a very unique way because there are multiple players involved and there's multiple targets for the regulations to be put on. So here is the prescription drug triangle. There are really three players involved in any prescription drug transaction. We have the physician, and in most, if not all countries, the physician is required to write a prescription for a pharmaceutical medication. We have a pharmacist, and in most, but not necessarily all locations, the pharmacist is the only one who can actually dispense that medication. And then we have the patient, who is may request the medication or is there to receive the medication, but ultimately consumes the medication. So we have these three individual players, all involved, all kind of wanting a piece of this triangle, but also all important regarding the distribution of prescription drugs. Now, outside of these individuals, we have associations who advocate on their behalf. So we have physician trade associations who advocate for physicians to, and other healthcare providers, it's not just physicians, to prescribe more types of pharmaceutical medications, and in some cases to dispense some types of pharmaceutical medications so they can start controlling more parts of the process and ultimately have more weight in the process and more control. We have pharmacists and pharmacist trade associations trying to make sure that the role of the pharmacist isn't diluted by enhancing the role of the physicians, but at the same time, they're advocating for a greater role of the pharmacist in healthcare decisions. So allowing the pharmacist to prescribe some medications themselves, allowing the pharmacist to change some medications if they find a counter interaction or they find something else, a better alternative. And then finally, we have the patient and the patient advocacy groups. And these advocacy groups, focusing on the patients, don't necessarily care where the prescriptions are coming from. They just want to make sure that the patients are getting the right medication in the most cost-efficient way that's going to help them the best. So whether that's a physician pathway, whether that's a pharmacist pathway, whether that's the more traditional physician-pharmacist pathway, they don't necessarily care, but they're just looking for the best way to get the drugs to help the patient in the fastest way possible. Now, the government can regulate all parts of this process and all areas of this transaction. There are regulations at the federal level and at the state level what physicians can do, what they can and can't prescribe, whether they can actually dispense the medication. There's government regulations on what the pharmacist can and can't do in terms of whether they can prescribe, what they can dispense, and who they can dispense to. And there are government regulations on the patients themselves. There are regulations on how much of certain prescription drugs an individual can actually receive at any one point in time. This is actually one of the ways we're looking at to try to slow down the opioid epidemic by limiting the amount of opioids an individual patient can receive at any one point in time. There are other regulations regarding age restrictions on certain prescriptions, as well as other ways to prevent certain types of patients from getting certain types of pharmaceutical drugs. And then outside of all of these players, we have the people who are actually producing the pharmaceutical medications, the people who are distributing them, and the people who are promoting them. So while the physician has to write a prescription for a drug, the pharmacist may have to dispense the drug, and the patient takes the drug. Nowhere in that triangle are the people who actually produce the drug themselves. So we have all of this outside influence and all of this outside lobbying and advocacy going on to try to get more prescription drugs on the market. They're similar to the patients in the respect that they don't care what the avenue is, and in reality, they probably want as many avenues as possible. They just want more of their product on the market. Now, there are other drug control policies that we do implement to control the use and distribution of prescription drugs. So we have counseling programs for pharmacists so they can identify who is and who isn't appropriate for different types of pharmaceuticals, and then allow them to actually counsel the patients in terms of taking different psychotropic pharmaceuticals. There are changes in price and reimbursement scheduling. So some pharmaceuticals, some psychotropic pharmaceuticals, we increase the price of to deter their use. or we lower the amount that a pharmacist or a physician will be reimbursed for by writing that prescription. Now, in some cases, this may simply cause patients to substitute one type of drug for another without changing the overall impact of the drug. And the patients themselves may actually not see any of these price changes because of drug health coverage through insurance plans. So they may only pay a copay, not a percentage or the full price of that actual medication. And then finally, we use guidelines and education, which is kind of the standard tool in public health and in prevention of addictions. And we provide this education to the physicians, we provide it to the pharmacists, we provide it to the patients. And what really comes out of all the research behind this is that it can be effective. It's kind of similar to mass media campaigns. They can be effective, but only in certain situations. So these guidelines and this educational programs are most effective when there's new information being discussed, when they're talking about adverse events, so the negative consequences of a new prescription, not the positive effects of a new prescription, and when they're delivered by peers, when they're delivered by people that we know and that we respect. So for physicians, for instance, new information that's delivered by patients will not be as respected as much and taken to heart as much as new information from other physicians. Alternatively, we can change prescriptions from something that we need a script for from a physician to an over-the-counter medication which anybody can buy. Essentially, it's a prescription drug available without a prescription. This makes them easier to obtain. It makes them easier to obtain. But for the patient, they're likely to be more expensive because they're not covered under health insurance plans. And they may actually be viewed as less effective, even though they're the same drug at the same concentration, because they don't need to go through that physician-pharmacist pathway. And finally, I do want to bring up again the idea that we do actually market prescription drugs, or some countries actually allow marketing of prescription drugs. Most of this does target the doctors through continuing education credits, through food purchases like lunch and small gifts like pens, swag. New Zealand and the US do allow that direct-to-consumer advertising. And the key message out of this slide is really that no matter what type of marketing is going on, it does significantly impact the prescribing behavior in the consumption of prescription drugs, particularly the psychotropic medications.